start your presentation?
Yeah.
Yeah, thank
Hello,
you.
everybody. My name is Khalod. I'm an intern doctor in EHS. And as said, I will be presenting my case report and literature review on CVT. So we'll go through the introduction, case presentation, discussion, and finally conclusion. So first of all, what is CVT? It's cerebral venous thrombosis. It accounts for 0.5% of all strokes cases worldwide. 75% are females in the fourth decade of their life. And usually there are common risk factors: inherited thromboembolic disorders, surgery, pregnancy, cancer, or hormone therapy. These are the most common risk factors we find in such patients. And then we have the clinical manifestation. Usually the patients present with intense headache, similar to ones described in subarachnoid hemorrhage. We can have focal neurological disorders that can present as focal deficits or seizures, and symptoms of intracranial pressure, increased intracranial pressure, such as papilledema and visual disturbances, aside from the headache. Yeah, and then treatment options. We have low molecular weight heparins. Right now they're the number one option for in managing, and they're shown in research to be more efficient than placebo and to be safer than unfractionated heparin as well. Unfractionated heparin is used in preventing clot formation and managing CVT cases as well. And then recently in literature, they've been describing direct oral anticoagulants to reduce the risk of severe bleeding and other complications. And then to come to the case, we have my case was a 37-year-old Filipino female nurse that presented to the University of Sharjah Hospital. She had no history of hormonal use, no underlying disease, hypertension, diabetes, or no previous surgeries. Her initial symptoms were double vision and intermittent occipital headaches, and that warranted the neurology doctors to make an MRI. So that was her first CVT episode. It was a CVT in the right transverse sinus. And then upon that, she was started on treatment of rivaroxaban for 6 months. And these were her MRI images. We can see lack of flow in the right transverse sigmoid, right transverse and sigmoid sinus. This was back at the end of 2022. And then after that, following the treatment, we also had a repeat MRI for the patient, which showed recanalization of the cerebral venous thrombosis after the rivaroxaban for 6 months. And then again, after stopping it with about 20 days, she presented to the emergency department with new headaches, and especially in the neck and the occipital area. And then because of her previous episode, they also warranted a new MRI to be done. And aside from the headache, she also had numbness and weakness in the right arm. So the new MRI showed occlusion in the superior sagittal vein and venous infarction in the left parieto-occipital and right frontal areas, as we can see here. This was halfway through 2023. So 6 months and 20 days after she stopped. 6 months after she took the treatment and 20 days after she stopped it. And then again here, we did an MRI with contrast. And here we see the lack of flow in the superior sagittal sinus. And then it started with that in the MRI, and then we started her on anticoagulation with enoxaparin for 8 milligrams. But in the ER, she showed rapid deterioration. It was at 15 at first, and then it rapidly went down to 6 to 7. And that's when we intubated her. We did a repeat CT scan after she was stabilized. It showed hemorrhagic cerebral infarction in the left parieto-occipital region, and that warranted the neurosurgeons to be involved. That's when they did an emergency decompressive craniotomy. And then after the operation, they reduced the enoxaparin dose, and they added an anti-epileptic as well. So here we can see the left-sided hemorrhagic venous infarction, and then the diffuse brain swelling and the ventricle size is reduced as well. And then this is after the decompressive craniotomy here. And then this is post the cranioplasty. This was done after around from like end of June till the beginning of November. And then following up with her, she had, after 1 month, she had a favorable regression of the hemorrhagic infarct. And then the last time before she was discharged from the hospital in December 2023, she had right-sided hemiplegia, upper motor neuron facial palsy, and slurred speech. And she was ongoing with physiotherapy and speech therapy. Since then, she went back to the Philippines to continue her physio and speech therapy. But that's the last account we have of her. And then to discuss the case, basically, CVT is a very difficult diagnosis, and it presents with many diverse clinical manifestations. As we said before, it's 3 times more prevalent in women. And our case was one of the 17% of cases that don't have any identifiable risk factors, which makes it even harder to diagnose clinically. And then when it comes to treatment options, lower molecular weight heparin are better and safer in terms to unfractionated heparin, but recently direct oral anticoagulants are seen as an alternative treatment. And then when we talk about chronic symptoms, 50% experience ongoing headaches, which makes it difficult to see if that is a side factor, side symptom, or if that's actually a new CVT. And then 15% end up requiring intensive care because of the severity of the headaches. 15% of CVT cases end up in death, and 25% experience worsening in the acute stages. And then 15% end up in severe disability as well, despite medical intervention like the patient we had. So the patient we have right now is going to be on chronic medications and chronic physio. And then recurrence rate, so when 1 year, it's 3%, and then it gradually increases. In 2 years, it's up to 8% recurrence rate. In 5 years, it's 12 years. And in 10 years, it's up to 18%. And that's basically my case presentation. It shows how important CVT cases is, how important it is to monitor it even after the initial resolution, because they're very high risk at having another CVT case even after stopping the medications. We need more research to understand the complex pathophysiology and to follow up with the patients as well. And each patient should have their own individualized management strategies depending on their own risk factors and family history. And that's it. Thank you very much. And these are my references. Thank you very much.